Hi, welcome to the section of cardiology, the study of the heart. This is Dr. Jaitly. In this particular section, I'll be talking to you about, are there any age-related changes in the heart? The answer is yes, of course. The body changes, the organs change over a period of time, over a period of decades, and pretty much so past the age of 60, on a multiple of every 5 years or so, the changes are quite noticeable, if you will, one way or the other macroscopically. That means either by looking at the heart per se or the arteries per se via imaging, or just by clinical assessment based on blood pressure, heart rates, and EKGs, etc., etc. Okay, so let's delve on some basic aspects as to where the changes happen. Now, as I said, in clinical examination, if you were to look at, the blood pressure starts to show some systolic elevations in past the age of 60, 65. And that's because of arterial elasticity, which is decreased. Elasticity decreased, but the stiffness increases. And because all of this happens, the pulse pressure tends to narrow, because the diastolic pressure will start rising first. And as a result, one would see a little bit of elevation of the diastolic pressure as well. Now, there is a decreased endothelial-mediated vasodilatation. Remember, we have an inherent way where we have vasodilators in lining and secreting from the endothelial cells within the arterial wall, the capillaries, and the venous wall. In fact, sometimes I say the biggest organ in the entire human body is endothelium. Correct. That's right. So it's not, a lot of people think liver is the biggest organ, or musculoskeletal system is the biggest organ, but actually it's the endothelial lining which constitutes itself like an organ, because it's constantly functioning and sending these endothelial secretions within the arterials or in the venous vascular system. Anyway, so you do have this vasodilatation, which is mediated via the endothelial function, that is decreased, and as a result the elasticity is decreased, and so is the stiffness that is increased. Now, this not only happens in the arterial bed of your coronaries, which are supplying the heart, but also it happens in the setting of the carotids, which are supplying the brain, obviously, and then in the peripheral arterial system, in the legs, etc., etc., including the aorta. So that's the vascular nutshell. Now, when you look at the cardiac per se, looking at the left side of the panel, you'll see the conduction disease, for instance, the atrium, the ventricles, and of course the valves. So when you look at the, say, let's start with the conduction first. The conduction, you'll see that between the SA node, that is decreased, so the heart rate tends to be a little slower as we age. And numerous APCs will occur because of the atomicity and the irritation that occurs within the atria. And there is an increased left atrial size, which is secondary to, again, stiffness from the ventricles, which we'll talk about in a second. But a decreased heart rate and a decreased variability of the heart rate. That means it's interesting how every beat normally varies in position in relation to our respiratory phase. Now, when we take a deep breath, the heart rate tends to increase. When we take a deep exhalation, the heart rate tends to decrease. So when the heart rate increases, what happens? The pulse or the QRS complexes will be closer. But if you look at the heart rate when it decreases, the pulse will be, each pulse will be far apart on an EKG or on a monitor, right? So the variability in relation to the respiration is decreased. That means there's not too much of variation that one sees with inspiration and exhalation at younger age or middle age, but in elderly age, one sees even decreased variations. Okay, so that is a good point to just remember. Now, AV node, when you come to this point too, that's the AV node. That also has increased conduction time. That means it takes longer for the pulse to traverse through. So obviously there is a delay. Sometimes the PR prolongation will occur, as a result. And then when you go further down, the bundles will also conduct differently, chiefly the right bundle. So right bundle, when it is present, that could be within the normal variation of the age-related phenomenon. But the left bundle normally signifies a disease, okay? So just remember that. If you have a left bundle branch block, that is signifying diseased left ventricle. But right bundle is considered as a normal variation with age. Now, valves will show some sclerosis, obviously, over a period of time, and then some calcification tends to occur in the valves here. Chiefly the mitral and the aortic valves we are very concerned about, because sometimes the stiffness or the sclerosis can lead to mitral stenosis, or aortic sclerosis leads to aortic stenosis of older age. So that could be a significant factor and needs to be followed initially, because if sclerosis is present but the valve is functionally has a normal orifice or normal valve area, it's not of any hemodynamic significance. But if it is narrowing further and further, then obviously that leads to stenosis of a clinical significance. And likewise, when you go to the ventricles, you'll see the wall stiffness occurs both in the right ventricle and in the left ventricle, as I've shown here, and diastolic dysfunction of grade 1. We'll get to the grades at a different time in different video presentations, but just so that you know, we have a systolic function and a diastolic function. So systolic function, assuming that that's preserved, the diastolic function tends to be compromised to a level of very mild nature. It's called diastolic dysfunction grade 1, which is normally present in elderly age groups. The right bundle, as I said, some VPCs can occur. That means premature ventricular contractions, just like we had the premature atrial contractions from the above atria. Now in the chambers below, the ventricles can also have premature ventricular contractions, and that's age-related. There's a prolonged ejection time. That means it takes longer for the ventricle to eject through the cardiac output through the aorta. And there's therefore also prolonged filling time, because the ventricle is more stiffer, so it takes longer for the ventricles to fill from the atria above. Okay, so these are some of the age-related changes, and let's again, in a nutshell, as I said, the valves will be sclerosed, and as long as they're not stenosed, it's not pathological or significant clinically. Ventricle stiffness is norm. Chiefly the diastolic dysfunction of a grade 1 variety can be seen. Arterial elasticity is lost and stiffness increases. And these are some of the changes that one sees. And of course, the heart rate variability, we talked about how that changes, including the slowing of the heart rate because of the SA node decreased activity with age. Thank you for your attention, and let's talk more and make it more interesting in our future presentations as well, and hope you stay tuned in. Thanks so much.